Well, thank you so much, everybody. Thank you for being here today. It looks like it's our first Zoom call meeting here with the health and long-term care. First things first, Miss Ann, would you please call the roll?
I am happy to. First, we have the committee members. Minnesota Senator Paul Etke.
Present.
New York Assemblyman Jarrett Gandolfo.
Present.
Ohio Senator George Lang.
Here.
Texas Representative Tom Oliverson. Wisconsin Senator Mary Felskowski. Now for the legislators that I have from registration, Arkansas Senator Justin Boyd.
Here.
Connecticut Senator Tony Wang. Illinois Representative Rita Mayfield. Michigan Representative Mike Harris. Michigan Representative Jerry Nyer. New York Assemblyman Ken Blankenbush. Nebraska Senator Bob Hallstrom. North Carolina Senator Gail Adcock.
Here.
North Carolina Senator Danny Britt. Ohio Senator Catherine Ingram. I'm sorry.
Yeah, I mean, and he was just
I'm sorry.
Go ahead, Ed.
Okay, thanks. Ohio Senator Kyle Kohler. Oklahoma Representative Mark Tedford.
Present.
Pennsylvania Representative Robert Ledbetter. And Pennsylvania Representative Greg Scott. All right, are there any other legislators on the line whose names I did not call?
Yes.
Brenda?
Committee member Brenda Carter, Michigan.
Thank you.
This is Jim Dunnigan from Utah. I believe I'm a committee member.
I believe you are.
Representative Brian Lampton, Ohio.
Great. Thank you. Is there anyone else? Last call.
This is Tom Oliverson from Texas. I'm here.
Hi, Dr. Oliverson.
Hi, I'm Wandrika McBride on behalf of State Representative Rita Mayfield from Illinois.
Okay, thank you. Anyone else? All right. That will close our roll for this meeting. And Mr. Chair, we do not have a quorum, so you will need to have a motion and a second to waive the quorum requirement and a voice vote.
Okay, can I get a motion to waive the quorum, please?
I'll move that. Paul Etke.
Thank you, sir. A second?
I second it. Brenda Carter, Michigan.
Thank you. All those in favor, please say aye.
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 We're good to go.
Aye.
We can waive the quorum and conduct business here today on this call. And anything else?
No, that's
before we
it
get
for
started?
no, that's it for the administration. Thank you very much.
Well, good afternoon, everyone. I am State Representative Michael Sarge Pollock. Most people call me Sarge. I did not earn it. My grandfather did, but I just am excited and honored to chair the Health Insurance and Long-Term Care Issues Committee. Thank you all for joining today's meeting. The purpose of this meeting is to conduct some business before our April meeting in Charleston. I truly hope everyone on this call has registered. If not, get that done immediately here. So as rooms and all are being taken up, this will help ensure we can efficiently address all the issues on that agenda in Charleston. We have a few models to discuss today, but we won't be taking any votes. This is strictly discussion. We'll be continuing this discussion on the NCOIL Improving Affordability for Patients Model Act and taking any comments on the model schedule for readoption in Charleston. So that's our agenda today. Let's get started. We'll begin with a continued discussion on the NCOIL improving affordability. I'll get it out here in a minute for Patients Model Act. We first started discussing this issue last April at our spring meeting, and a lot of work has gone into developing this model. You can view the model on the website with all the other materials for this meeting. But before we go any further, I'll turn things over to the sponsor of the model and NCOIL and immediate past president and Texas representative, Dr. Tom Alberson. Representative, please go ahead if you're available.
Thank you, Mr. Chairman. I appreciate it. So I'm honored to be able to pick up the work that our colleague Deborah Ferguson started on this model. We're very excited about it. I'm anxious to hear any comments that you have. I will tell you that from my perspective, both as a lawmaker, but as somebody who sees the application of facility fees and what that's doing to our healthcare as a provider from the inside, I am very concerned about the rise of facility fee charges, particularly as relates to physician practices that are acquired by hospital systems as part of a vertical integration strategy. So those are sort of my primary issues. I don't have any other specific comments, Mr. Chairman, but I'm happy to take any questions. And as I said, I'm very much looking forward to the discussion as we move forward on this. Thank you, sir.
Thank you, Dr. Alverson, for your comments. In terms of the format today, we'll first open things up to our scheduled speakers and then any interested parties that would like to speak. After that, I'll open up things to any of our legislators for questions and comments. First, we will hear from Lucy Culp of the Leukemia and Lymphoma Society. Lucy, I hope you're on the call. Thanks for being here today. Please go ahead.
I am. Thank you. Hi. I'm going to attempt to share my screen and share a couple of slides. I hope. How's that look?
Good.
It works.
Hooray. Okay. Hello. Thank you all. Representative Pollack, members of the committee, thank you for the opportunity to speak. Representative Oliverson, thank you for sponsoring this Model Act. My name is Lucy Culp. I lead the state government affairs team for the Leukemia and Lymphoma Society, and I also wear another hat, and that's as a consumer representative to the NEIC. So for folks who aren't familiar with us at LLS, our mission is to cure blood cancer and improve the lives of patients and their families. We really exist to ensure that access to treatments are available for all blood cancer patients. So we fund research to advance those treatments. We provide patients and families with one-on-one guidance and support, really from a whole team of social workers and nurse navigators and support groups. And then we also advocate for policies that protect and improve patient access to treatment. And, having that kind of one-on-one patient connection is just so important to making sure that the policies that we pursue, right, are in the best interest of the folks we serve. And it's with that mission in mind that we're really pleased to support this Model Act, and just want to offer a couple of suggestions for you all to consider as you consider adoption. And I want to say too, I with my NEIC hat on, I know we use the term consumers a lot when we talk about insurance, but I'm going to use the term patients here because I think it's important just to remember that that's who health insurance consumers are, right? They're patients, many of whom are dealing with really complex and chronic diseases. So I wanted to just talk a little bit about kind of why this is so important to us. Blood cancers are extraordinarily expensive to treat. As just an example, the average cost to treat acute leukemia in the first year is about $500,000. And these diseases are also incredibly complex to treat. They vary wildly and in kind of their intensity and the pace of symptom onset and the length of treatment. And even patients who achieve long-term remission are often in need of heightened surveillance and monitoring throughout their lives. And what that means is lots and lots of doctor's visits of all kinds, right? Hospitals, clinics, primary care, labs, you name it. And that's over years and years. So in short, blood cancer patients are very high utilizers of healthcare services and their health insurance plans, and are therefore, really highly impacted as those markets change and shift. And we know the price of cancer care and ultimately the consumer cost of care is rising at a really alarming rate. I mean, you all know this, right? We've all felt it in our personal lives. And, I think that's why you would be looking at a model like this. Patient out-of-pocket costs are increasing through higher deductibles, copays, co-insurance, and thus, patients are less able to afford the care they need, and it compels them to delay care or even forego treatment. And higher prices and extra fees become medical debt. We know that 1 in 3 Americans currently have medical debt. About half of cancer patients report having to take on debt due to their treatment, and about 42% say that they deplete their life savings in the first 2 years. So a driver of those increased costs, and Representative Oliverson mentioned it, of course, I will say not the only driver, but certainly a contributing factor, is hospital consolidation. In recent years, significant consolidation has taken place in the healthcare sector, and the research is really clear that hospital mergers lead to larger entities with more market power that can then negotiate increases in their prices, which then translates to higher costs for patients. Is there a question? Or is that just a not on mute? Okay, I'll keep going.
Keep going.
Okay, feel free to stop me, but I'll keep going. Unfortunately, what the research doesn't show us is a correlating increase in quality, right? So we can't say that as prices go up, the care is getting better. And in fact, while there's some variation in the research, many studies are showing a reduction in quality, lower payment satisfaction, and a reduction in access to services, especially in rural communities as hospitals continue to consolidate. And the research also indicates that facility fees are one of those cost drivers. So I think you all probably already know, because you've been talking about this model for a little while now, but you know that a facility fees is a charge assessed by a healthcare provider that is separate from and in addition to charges for professional services. So for an example, a person who visits a provider for, say, a routine blood draw may be charged for the blood draw itself, but then also receive a separate additional fee. We acknowledge that there are some cases where a facility fee might make sense, and we're not advocating for their full elimination. Historically, most facility fees were assessed by large standalone hospitals to cover costs, right, associated with running the facility, because that may not have been fully reimbursed through negotiated rates. So for instance, the cost of maintaining like a 24/7 emergency department, that's a frequently cited example of what facility fees may help finance. But now patients are increasingly being billed for these fees in settings where they really wouldn't have traditionally seen them. And again, that's happening because large systems are able to tack fees onto bills for services provided in the outpatient settings that they own, even when they're separate and apart from the main hospital campus. So I'll just throw out another example here, a person who visits a primary care doctor for that routine physical every year. They could be assessed a hospital facility fee if their doctor's practice is owned by that hospital, even though they never set foot on the actual campus, which was, ostensibly the need for the fee. And this can be particularly surprising for patients whose doctors are newly acquired. I mean, you can kind of just imagine a fee you wouldn't have been assessed and then could kind of suddenly be assessed because your doctor's office was purchased and you may not have even realized. We were out, one more example, we were recently contacted by a patient who, a blood cancer patient who went to her doctor for a fairly routine visit. She wasn't surprised, of course, to receive the bill for her portion of what was due, right, her copay. But she was very surprised when she received a facility fee for almost the same amount. So it essentially doubled what she owed out of pocket, and it came as, 2 separate bills. So moving to the Model Act here, all of that's to say, that's really why we're pleased to support the Model Act. We would just urge the committee to consider just a couple of modifications to ensure that it sort of offers even stronger protections to patients. First, So we'd suggest that the model include a prohibition on those services provided through telehealth, sort of just as it does with off-campus locations. So rather than just those outpatient services billed using evaluation and management or E&M codes, we just see no reason that services provided in a virtual setting where there's no facility would be treated any differently than those provided in an off-campus setting. Second, we'd really urge you to consider whether it is ever appropriate for a facility fee to be charged directly to a patient rather than to their health insurance provider. So, as we've discussed, there might be places where a facility fee is allowed and appropriate and necessary. But, is patients and consumers pay an increasing amount in premiums each year. And in return, they expect a level of reasonable cost protection when they need to access their healthcare, along with the understanding that, what they're paying will contribute to their deductibles and their out-of-pocket maxes. So when we think about this from a patient's perspective, right, getting billed for a facility fee outside of their health plan really feels like a surprise bill by a different name. And Congress, along with numerous states, many of your states, have already acted in a bipartisan manner to really rein in surprise bills. And we just think, this committee could continue that progress by ensuring that allowable facility fees be included in charges sent to insurers rather than ever going directly to a consumer as an added bill. I mean, and additionally, I'll just say here too, we think health plans are probably much better positioned to evaluate and negotiate these plans than consumers are on their own. So again, just thinking about that as part of your assessment of kind of where these are appropriate and how they're billed. And finally, we're very supportive of the language in the model that ensures that the provider identification number, the NPI, that submitted claims accurately reflect that specific site of where the person receives their care. We would just encourage the committee to consider amending this section to require that claims provide sufficient information so that you can identify the specific site of service and the larger hospital system or organization. Our thought here is being able to identify and track those linkages between individual sites and kind of their ownership structure will help fill the knowledge gaps of how consolidation impacts patients. And with that, I will just say thank you again for your time, and I'm happy to stick around and answer any questions. Really appreciate you all taking this on.
Thank you, Lucy, so much. Great information, great examples that you shared with us. Again, we've got one more speaker, and then we'll open it up to our legislators to have questions available for those. We'll now hear from Terrence Cunningham of the American Hospital Association. Terry, hope you're here on the Zoom call. Thanks for being here, and please go ahead.
Thank you so much, Mr. Pollack, and I'm going to share some slides as well. Thank you all for having me. I really appreciate the time to talk to you about this model legislation. One moment, let me just get this. Can you all see my screen now?
Yes.
Excellent. Thank you all so much for having me. My name is Terrence Cunningham. I'm the Senior Director of Administrative Simplification Policy with the AHA. Really appreciate the opportunity to discuss the Improving Affordability for Patients Model Act. Today, I'll quickly go through kind of some of the overview of facility fees and what they pay for and what the purpose is. I'll talk about some of the specifics of hospital care that differentiate hospital care from other settings. I'll talk about the concept of physician acquisition and kind of what the drivers of some of the physician acquisitions might be. I'll also talk about the NPI issue and the honest billing provisions of the bill, and the need for off-campus facilities to have unique NPIs from larger facilities. And then I'll just offer some general takeaways. So whenever you're discussing legislation like this, I on the surface, I get it, right? The site neutral. Why would a bill for a specific bill for a service in one setting and a specific bill for service in another setting, why would those differ? If it's the same billed service, shouldn't they be the same? And I get that. What I would offer is I think there's a little more nuance, and I would hopefully I'm able to convey kind of some of the nuance that might differentiate and explain why there are different charges in these settings. First, I want to do is just kind of talk about what facility fees cover, specifically as they compared to professional fees? Obviously, professional fees cover physician services. This is right. The general concept, you bill a specific CPT, you've got a rate associated with that CPT, and this is what the physician is reimbursed for. Facility fees, as they are unique to hospitals, cover a lot of additional things that might not be something that is necessary in these other settings. And so things that hospitals need to cover in order to be a successful hospital for patients. And this includes things such as nursing and supporting medical staff, pharmacists, medical equipment and supplies, clinician training, significantly enhanced regulatory compliance, things such as that, things such as that, which again are unique to the hospital setting and kind of are one of the justifications we would offer as to why facility fees are essential parts of the care delivery system and the payment system that we have today. So hospital care, I want to indicate, I talked about you've got two different settings, the same billed service. I would note that hospital care is inherently different than other settings of care. In terms of patient type, hospitals care for enhanced acuity of patient. They care for sicker patients. This is consistently supported by research, and larger number of uninsured patients are visiting hospitals as opposed to some of these other settings. And so with that, causes increased costs of caring for these particular patients. Additionally, the costs for delivering care at a hospital are not equivalent to some of these other settings. For one, hospitals generally are keeping at least portions of their facility open 24/7 for care. As I mentioned before, they have a significantly enhanced amount of comprehensive licensing, accreditation, and other regulatory requirements that they must meet in order to be a successful hospital. Another thing that hospitals provide, and I don't know if this is often talked about enough, is hospitals have settings that don't produce revenue but are essential public services. And in order to do that, one of the necessary parts of hospital financial settings is there is a certain amount of cost shift that's just inherently necessary in order to provide some of these public services. What do I mean by that? Well, there's certain things such as behavioral health, nephrology, burn units, infectious disease units that consistently do not that the margin is below zero. They are not revenue generating. In fact, they cost more than they actually bring in for delivering that care. And in order to continue to provide these settings, hospitals often need to have higher margins in other settings, such as an outpatient department, that offset the losses that they're just inherently going to have with some of these settings. And so if you eliminate a lot of those margins that might exist in a hospital outpatient department or other setting that might be where revenue might be generated, it threatens the viability of the hospital to deliver these other settings. One thing that's not on here that I do think is also worth noting is in certain settings, maternity care is obviously, maternity care you have to deliver somewhere between 250 and 300 children a year. Around there is the estimate for a hospital to kind of break even. And so in a lot of the rural settings in particular, if you've got a maternity center that's not delivering that amount of infants each year, they're going to be in the negative as well. And there's going to need to be margins and cost shifting that's involved in order to keep those essential facilities open. And so one of the concerns I have when we look at these bills is not seeing the whole picture as to where some of that financial might need to be cost shifted in order to cover some of these other services. One of the things that we often hear is that the increased outpatient rates or the increased hospital facility rates are what are driving the physician acquisition of hospitals and physicians being gobbled up by hospitals in order to charge these higher rates. And the data just doesn't support that. While there is an issue with independent physicians being acquired, it's most often private equity and health insurers. And right, that seems consistent. You've heard significant amount. Optum is the largest employer of physicians in the country. And there's a lot of, and so the data shows that while physician acquisition is an issue, it's not hospitals that are the ones who are consistently and driving this. And I would offer that oftentimes, why is this happening? Well, they are being acquired. And I would say oftentimes it's physicians are not being reimbursed sufficiently by the health insurers in terms of their total cost for their services. And the administrative complexities and needs in order to jump through the hoops necessary to receive reimbursement from health insurers, things such as prior authorization or prompt pay issues or the documentation requirements and stuff such as that make the administrative costs continue to rise, and then you don't have a sufficient amount of reimbursement to cover those. And so what a lot of physicians are doing is employment becomes a more practical solution because that takes off that administrative headache. And again, it's occurring, and I think there's a need to potentially address some of those issues. I just don't think this is the way to address that particular issue. The other concern I wanted to talk about is the honest billing provisions of the bill, and specifically the need for new NPIs for off-campus outpatient departments. One of the things that I've heard in discussions involved, and I won't speak for the NCOIL, I haven't heard the NCOIL discussions, but I've seen discussions on this, is there's an inability to know from a hospital's outpatient bill whether or not that was an off-campus facility or an on-campus facility. And I think a lot of this is driven because there's inherent differences between the professional claim and the institutional claim. The professional claim is what a physician will submit for their services. And on that, it's going to have what's known as a place of service code. And that's going to be used to flag, and there's a specific code, I think it's code 19, don't quote me on the specific number, that'll clearly indicate this is an off-campus hospital, this is an off-campus outpatient department. The institutional claim doesn't have that. So I think frequently people say, well, there's no code to be able to identify this as an off-campus outpatient department. But that's not necessarily the case. It's just the differences in terms of how these bills are processed that might make it different to know. But there is a clear way in which a health plan or anyone else looking at these bills can tell whether or not a health plan can tell whether or not this was care delivered at an off-campus facility or otherwise. Specifically, a health plan, in order to be processed by a health plan, you're going to need to have a type of bill, which is FL04. It's a specific segment in an institutional claim, and that's going to indicate whether it's outpatient or inpatient. There's a whole bunch of types of bills, but for the purpose of this discussion, there's an outpatient claim, so there's going to be a specific type of bill that's used. And then in order to, when you put an address on a claim, it has to be the service location. It's not the parent company. It's got to be the service location. And in order to have an alternate from the main campus service location, those need to be registered with health plans typically. And so the health plan will know right away, oh, this is the address I have on file for that off-campus facility. This is not on campus. And so, yes, there's a different way of determining whether or not this is an on-campus versus off-campus, but that's not to say that there's not a way of determining it. And health plans can clearly determine whether or not care is taking place at an on-campus facility or an off-campus facility by looking at these two specific segments of the claim. I don't want to take up too much of your time because I want to make sure we have time for questions, but I do just want to leave with a couple of key takeaways in what I spoke of. Facility fees are essential to providing the unique type of care that are provided by hospitals. Specifically, eliminating facility fees jeopardizes the financial viability of certain areas of hospitals, and it could threaten the ability to provide these non-revenue generating services, particularly in rural settings where there might be a lessened patient population. I also will note the reduction in independent physicians is certainly something that might be concerning, but hospitals aren't the driving factor. And again, I would note that I think the driving factor on this are health insurers and other payers not paying a sufficient rate for physicians to remain financially viable and creating more and more complex both coverage, such as, and I know Lucy talked about this, there's more and more coverage, high deductible health plans that are shifting cost responsibility onto the patient. And again, in those situations, when you shift more onto the patient, you've got more bad debt that's inherently going to occur because you don't collect at the same rate from. And so there's a lot of financial pressure on independent physicians that might be leading to them no longer being independent physicians, instead turning to employment. But it's not, the concept of hospitals driving this is not backed up by the actual data. And then finally, again, the NPI for off-campus departments, it doesn't seem like it's necessary because you can already determine this stuff by looking at an institutional bill. And so really requiring this is only going to add to that administrative cost that's uncompensated by the professional fees and things that providers are going to have to address, and it'll make the care and the billing even less efficient than it might be today. With that, that's all I've prepared, and I really appreciate you giving me the time, and I'd love the opportunity to answer any questions you might have. Thank you all so much.
Thank you, Terry. Great information. We may have a couple of interested parties wishing to speak as well. now is your time. So if you're anyone else here that want to have something to say on this particular model, now's your time. Anyone else? We'll get to the legislators just in a second. Just want to open that up for anybody else that's interested in sharing their thoughts on this particular model.
My name is Eric Waskowitz. Can I just jump in, or didn't want to cut the line?
Go ahead, Eric.
All right. Thank you, Chair Pollock. I just want to kind of address my comments to you, to Vice Chair Boyd, and members of the Health Insurance and Long-Term Care Issues Committee. My name is Eric Waskowitz. I serve as Senior Policy Manager for United States of Care. We are a nonpartisan, nonprofit organization, works in the states to ensure that everyone has access to quality, affordable health care. We are new to the NCOIL world, but just very interested in the work that you're all doing to address facility fees, and I'm looking forward to meeting all of you in Charleston. I would say, for the most part, my remarks, I'm going to align myself 100% with what Lucy had mentioned related to the problem that facility fees pose to patients. I'll say, first and foremost, hits close to home for me. I received a $180 facility fee at my primary care doctor's office for a strep test. This is a strep test, who knows how much that costs, but to kind of think through what that looks like on a bill was a bit of a shock to me. So I would say I'm certainly part of the 80% of people that really are supportive of action to address facility fees. Looking at this draft model act, we as US of Care are supportive of the facility fee prohibitions and transparency requirements. The draft model also ensures hospital compliance, and we believe that this legislation really does align with the approximately 18 states that have passed some sort of protections related to facility fees. I will say, in addition to the consumer protections found in the Draft Model Act, there are a couple areas of focus that I think we feel could be addressed to strengthen the legislation even further. The first is something that Lucy mentioned earlier today regarding national provider identifiers, or NPIs. We are supportive of language in the model to require these unique NPIs for off-campus providers. And I would say on top of that, some sort of mechanism to kind of really establish
Sorry, I missed your call. You okay?
To establish a connection between parent hospital and affiliated off-campus provider to make sure that we know where these fees are being charged. We as US of Care, we've spoken with state all-player claims databases, and they've told us it's very difficult to kind of identify where these fees are being charged, even with unique NPI language. And so we feel some sort of clarification is needed. And then the second item relates to data collection. So, we at US of Care, we've been very supportive of language in this draft model legislation requiring hospitals to submit a publicly accessible report on facility fees. At the same time, we would encourage the committee, if possible, to think through a requirement that states complete some sort of analysis or evaluation to kind of understand the impacts of facility fees on people's access to care, as well as the healthcare system more generally. So looking at providers, hospitals and others, consumers, and the like. This has been done in several states so far that we thought has been pretty successful. And then one final thing, we just want to encourage NCOIL here to kind of think through solutions beyond facility fee prohibitions, things like site neutral policy or fair billing policy, policies that kind of address the commercial market in states. We feel like doing so would secure even more savings for people, employers, and others, while also making sure to kind of lower the cost curve for the healthcare system more generally. So I'll pause there and stop and just want to thank the committee for the opportunity to speak here and urge you to consider us a resource moving forward. Thank you.
Thank you, Eric, for that input on the discussion on this particular model. We have up next Miss Randy Chapman. Randy, please go ahead, get started.
Yeah, thanks. Thanks, Mr. Chair. I will keep my remarks very short because we have spoken a couple of times on this model. I just want to thank Dr. Oliverson again for taking up the mantle to sponsor this model. We truly appreciate that, and I think this. Sorry.
No. Go
And,
ahead, please.
Okay, thank you. And yeah, when we, just think the policy solutions that are included in this model can really go a long way to help consumers, patients, our members achieve more affordability in their healthcare. I'm not going to reiterate all of the great information that Lucy and Eric have both shared. I will say, though, I am thrilled that, representing the industry, that we are aligned with patients and again, aligned with our members here on this issue. And we think it's just, essential to address what's going on in terms, to help make healthcare more affordable for patients. There are a lot of levers that contribute to high costs, and this is just one of them. So thank you again. I appreciate the time.
Thank you, Randy, so much. At this point in time, we're getting ready to start in on the Q&A. And we'll open that up to our legislators. Are there any questions or comments from any legislators? I think may have one or two here. So,
hey, Sarge, I have a comment and a question, and I've got a hard stop in about 7 minutes. If you
please
can
go
indulge
ahead.
me, perfect. Thanks.
Yes.
First of all, I want to thank Tom for bringing this forward. Last year in Ohio, we enacted hospital transparency bill, and included in that, we wanted to include some facility fee language, but it was only aspirational. And at the last minute, we decided to pull it all together. It is something that we want to work on. The concern I have and a potential amendment to fix it would be when these hospitals purchase a physician's practice, I'm assuming, as most business models, they use a multiple of something, revenue, EBITDA. They use a multiple of something to purchase that practice. And this gives them the opportunity to realize they're going to have additional gains from the facilities, the tools, if you will, at the doctor's office that they currently don't enjoy. So my concern is that a hospital offers a higher multiple based on the fact that they're going to enjoy higher revenues on the facilities at that firm than the practice otherwise would have received. One potential amendment, and don't hold me to the details, Chairman, because I really don't know, but my assumption is when a hospital buys a practice, they like to have it all paid off in 5 to 7 years. That's just an assumption based on my businesses I operate in. And when I buy a practice, I have a 5-year model. When I buy a building, a 7-year model. I truly don't know what hospitals do. But if that assumption is correct, in order to give hospitals a longer runway and a softer landing, I would recommend we consider grandfathering all existing facilities in for a period of time. My opinion, that should be about 3.5 years. That way, if a hospital bought a practice 6 years ago and they have 1 year to go, they're going to enjoy fees that they should not otherwise have enjoyed once that building is paid off. And so they'll take advantage of it in that scenario. But a hospital that just bought a practice a year ago, they're not going to have the full 7 years. They're just going to have an additional 3.5 years. So that is an amendment I would like for the sponsor to consider, and I'll be happy to help them with some language. And we're actually working on something similar to that in Ohio. And some concerns about the testimony that we heard. I heard Lucy say that we should direct the bills to the insurers, not the individuals. And if that means the responsibility of paying those to the insurers, we will just continue to drive up cost on the small business markets and continue to drive more and more of those small business markets out of the umbrella of state regulations. I know in Ohio about 10 years ago, 20% of everybody insured was insured in a small market plan. Today, that number is only 10% because these small businesses have figured out how to pool their resources, how to get to a self-funded world where they don't have to follow our directions. And for the American Hospital Association, I appreciate the fact that you have items that you lose money on. I don't understand why a hospital would do that, but I don't understand your model. I understand why a retailer would do that. You want a loss leader to get people in on very attractive items. And I don't think it should be our responsibility to help you make up for those items that you have priced at a loss or at a lower margin. That would be my pushback there. And Chairman, thank you for the opportunity to make the comment and to pose what was supposed to be some questions, but I think it ended up being more comments for the two presenters. Thanks.
Well, thank you. And those are valid points. I'm sure Dr. Alverson would love to continue this conversation further on. I know you're at a hard stop here in a few minutes. I think it would be great for you and again, Dr. Alverson to get together on your amendment language. And again, due to continuing this Zoom call and things are happening, please reach out, Lucy. You guys reach out to anybody that had his concerns, his valid points to kind of help. Again, that's what this Zoom call is all about. So any thoughts real quick here before we move on?
Okay, Sarge, this is Representative Brenda Carter. Let's see if
Go ahead, Representative.
Yes, last year let me get the camera. Last year we were looking at introducing similar legislation in the state of Michigan where we had substantial opposition from the hospitals. It was great to hear some of the feedback that I heard from both sides today, and we're going to revisit it again. But I want to ask the question, how does this model act address the out-of-pocket cost for the patient? You know, that's the primary concern that we are with, you know, that the facility fees are costing the patients. And cost of healthcare is already rising to the point that we're increasing our pool of underinsured and uninsured people. So, you know, we can address that, Representative Oliverson. We can go offline and talk about it. And I can also bring my model legislation, not my model, but my legislation with the bills we have in Michigan to Charleston.
Thank you, Representative. At this time, Lucy, Terry, would you care to comment on any of the comments from the two representatives at this point?
Sure. Yeah, I'd be happy to. So I think our concern in part is that oftentimes facility fees are actually billed directly to the consumer, to the patient, rather than going through their insurance, right? So it's like a separate bill entirely. Like they'll get their explanation of benefits, they'll get the information from their insurer, they'll pay their copay or their part of the service, and then they'll get this other separate fee. And so that I think maybe in part addresses your question, Representative Carter, but I mean, I think we'd be really interested to talk more about if there are additional ways to provide additional consumer protections, you know, make sure that as facility fees go away, it's not just passed on to patients in another way. But ultimately, I mean, what these are is charging more for the same price because it's being provided, charging more for the same service because it's being provided in a space that's owned by a hospital versus one that isn't. And we just don't think that's fair. Right. So I think I hope that helps kind of answer, I think maybe both of your questions. I hope that helps.
Terry, would you care to comment?
Sure. I think in terms of things being not covered by a health insurer and having to go directly to patients, I think we would agree. We would like things to be paid for by the health insurer. And I think that's, again, might be a cause of a lot of these issues is we want facility fees and everything else to be something that's comprehensively part of your benefits package. And the fact that these benefits packages have been consistently eroding and you've got coverage that doesn't pay for what it maybe should might lead to some of these things. And in terms of services that do not generate margins, I mean, I think hospitals feel hospitals as, you know, a specific hospital to a community, they provide public health services that are essential. And I think hospitals take that seriously. And so there is a certain amount of cost shifting. There are non-revenue generating services because that's what hospitals are supposed, you know, you generally expect a hospital to be somewhere where someone can have a baby and doesn't have to drive crazy amounts of time or have an issue to access. And so I think it's just inherent to how things are handled so that you can provide the comprehensive healthcare, which is expected of hospitals. In order to do that, there's cost shifting. And that's kind of what brings the kind of, there might be some services that generate revenue and some that don't, but we think both are essential to what it means to actually provide hospital level care. Thank you all so much.
Thank you so much. Discussion, communication is so important to come to a point and create good models. Ms. Ann could provide those emails as these continue on conversations on some questions and dialogue. At this point, thanks everybody for being available, bringing in the input here. Representative Dr. Alverson, do you have anything else as far as closing remarks?
Yes, sir, Mr. Chairman, and I really appreciate the good discussion, especially the comments by my colleagues. I'm happy to visit with you. Just a couple of observations. Number one, I think it's important to Representative Carter's concern. I think it's important to understand that what we're talking about here is a facility fee that is levied when a patient goes to see a doctor in the doctor's office. And historically, when a physician contracts with a health plan, there is a certain amount of attention in that global fee that is paid to that physician for reimbursement of the cost of overhead. And so what we have here is a scenario where essentially the cost to the patient has been doubled or tripled vis-a-vis something that 10 years ago was just included as part of the professional fee. So it is a true doubling or tripling of the patient cost. So by prohibiting these fees, which didn't exist until relatively recently, I would point out, you are actually returning us to a state of normalcy. As far as the comments about hospitals and under or uncompensated care, I would just simply point out that in my experience, especially for my lawmaker friends who serve on appropriations in your state or Senate Finance, you have undoubtedly heard the terms DSRIP or DISH. Our states already, and the federal government, already subsidize hospitals across the board for services that they render and provide in under or uncompensated cares. There are multiple buckets from both the state and federal government that are designed to account for these shortfalls. And to the comments I heard earlier, is from a business standpoint, from my good colleague from Ohio, I would just say that, you know, it's not as bad in the hospital world as you think it is, because, you know, unlike a regular business, as they're making these decisions and they have lost leaders, they have literally tranches of both state and federal dollars that they are entitled to. The only thing they have to do is prove that they're doing a certain amount of under or uncompensated care in certain particular areas like emergency rooms, outpatient settings, and labor and delivery specifically. And the last thing I'm going to say is that with respect to my friend from the Hospital Association, I would just say that I don't believe, in my experience and my research on this issue, that the reason why hospitals acquire physician practices has much of anything to do with the actual facility fee itself, nor is that the main business model mechanism by which reimbursement is gathered. It has more to do with controlling the patient's chart and the continuity of care and the referral patterns. And you see this very clearly when you look at the types of practices that hospitals like to acquire. These are oncology practices, surgical practices, primary care practices, and OB-GYN practices. And the reason they do that is because if your primary care doctor is working for the hospital and you need a stress test, guess where that stress test is going to be done? If you need a referral to see a cardiologist, guess whose cardiologist you're going to see? If you're an orthopedic surgeon and your practice is owned by the hospital, or a general surgeon, guess where your surgery is going to be done? It is going to be done at the hospital. And so I think one of the main driving factors and benefits for a hospital or a hospital system in terms of acquiring physician practices is actually controlling the patient's chart and controlling referral patterns and making sure that the hospital is benefiting from services that may or may not be competitively priced with respect to what's available in the market, because now it's a closed shop and a closed system, and there is no competition, because essentially the referring doctor is obligated to send the patient to a practice, a facility, or a treatment that exists underneath the hospital site license. So I just want to make sure you guys have that context. All that being considered, Mr. Chairman, I'm grateful for the chance to be with you today. I'm really looking forward to working with all of you on this. I think we have a real grand slam here in terms of a meaningful model for NCOIL that we can take back to our states and really, really help consumers have better affordability in healthcare. And with that, I'll just return it back to you, sir. Thank you.
Absolutely. Thank you so much, Representative. Anyone on this call, and please reach out to Representative Alverson, myself, or NCOIL staff with any questions or comments on this particular model. This is good stuff. Great discussion today. Again, continue this discussion on as we lead into Charleston, our spring meeting. Next on our agenda is an opportunity for comment and discussion on the model law scheduled for consideration of readoption at the spring meeting. The two model laws scheduled for consideration at the spring meeting are there's two of them: Transparency and Dental Benefits Contracting Model Act, originally adopted in December of 2020. And then the other one is a short-term limited duration insurance model act, originally adopted in the September 2020 year. As a reminder, per the NCOIL bylaws, all NCOIL models are scheduled to be considered for readoption every 5 years. If a model is not readopted, it sunsets. These models will not be voted on here for readoption today. Rather, this is an opportunity for any comments or discussions in advance of the April meeting, where the actual vote will take place. I'll start with the Transparency and Dental Benefits Contracting Model Act. I'll open it up to the legislators first. Do any legislators have any comments or questions on the model?
This is Senator Boyd in Arkansas. Assemblyman Gandolfo and I have been in discussion with the American Dental Association about some amendments to the model we would like to sponsor and have the committee consider, including adding two issues: assignment of benefits and limitation on erroneous payments. These can be discussed further during the in-person NCOIL spring meeting of the Health Insurance and Long-Term Care Issues Committee.
Thank you, Senator. NCOIL staff, please take note. Anyone else?
Chairman,
Yes.
if I could just jump in and echo that from Senator Boyd. I appreciate him taking the lead on this, and I'm happy to join him and hopefully co-sponsor this. I think some of these amendments that we are going to be discussing will go a long way in improving the dental experience for the end user, in this case, the patient. So yeah, I would just like to throw my support behind that as well.
Absolutely. I will just chime in. We're in session right now, and I'm sponsoring a dental bill here in Kentucky right now. So hopefully, cross our fingers, it gets over the finish line. Anyone else on this particular model law? Again, NCOIL staff, please take note. Thank you. I'll now open it up to any interested parties that have any questions or comments.
This is, if I just jump in.
Yes.
Great. Hey, everybody, this is Chad Olson, who hopefully won't be quite as tongue-tied, from the American Dental Association. Just chiming in to say thank you to Senator Boyd and Assemblyman Gandolfo for considering the amendments, and we're looking forward to working through them in the future. Thank you.
Thank you. Anyone else?
Yes. Hi, Representative Pollock. My name is Bianca Bilali. I'm with the National Association of Dental Plans, and have a few comments on the potential reopening of this model act. At this point, we would recommend, and I apologize, I speak on behalf of the National Association of Dental Plans, as well as DDPA, which is the Delta Dental Plans Association. At this point, we would recommend that the Health Committee does not reopen this act. The current model was discussed and debated at length in 2020, which I know many of you are very aware of, and it contains important policies that bring a lot of legal clarity and consumer protections to the dental contracting space, including increasing transparency for providers, ensuring access to quality dental care and network specifically for consumers, as well as providing a lot of opportunity to providers to elect participation, whether that be in the virtual credit card provisions or in the network leasing. And I do want to note there has been broad adoption of the current model, which to us indicates that it contains strong policies that were the right outcome 5 years ago when adopted. Specifically in regards to the virtual credit cards portion of this, there are 11 states that have adopted the model and or remain substantially similar to the model, 6 following exactly, and 5 adopting a very similar approach. And then an additional 15 that have adopted the network leasing provisions in this model, with 6 aligning exactly and 9 following it very substantially. And just want to note the substantial impact that would occur from amending this NCOIL model, and requiring for readoption by some of those states that have already considered it. And with that being said, would just want to note that if the committee ultimately does decide to reopen the model, we would respectfully request the publication of any proposed amendments, as we've not seen any to date, and allow for ample time to respond and review, and respond to that text. As you're aware, NADP as well as DDPA are both member organizations, and we would want to make sure our members have the opportunity to review the potential impact of any amendments to the model. So we appreciate you considering this and taking the time to hear our input.
Thank you so much. And well, it does sound like we have a lot of discussion on this model between now and at the spring meeting. I look forward to working with everyone on this and the best path forward as it comes to time. Based on how the discussions are going, the committee could readopt the model as is for another 5 years, but obviously there is some more dialogue here today, or we can readapt it on a meeting-to-meeting basis so that interested parties can work with Senator Boyd on the concepts that he's discussed and we have talked about today. If anyone has any questions or comments on this, please reach out to myself, Senator Boyd, or to the NCOIL staff. Now we have the short-term limited
Mr.
duration.
Chairman,
Yes.
Just one quick comment. In response to Bianca's comment, rest assured, any language that would be amending a model will be included in the 30-day materials, which are about a couple weeks away, if not beforehand. So there will be ample time for review and comment on anything. That's all. Thank you.
Yes. Thank you, Will.
Yeah, thanks, Will. Thanks for clarifying that. So we'll move on due to time and some other, but good discussion there. Now we have the short-term limited duration insurance model act. Do any legislators have any comments or questions on that model? Seeing none. Anyone else? No? Well, sounds good. Anything?
Interested parties?
Yes. Interested parties are up now. Go ahead, please.
Thank you. JP Weisky, representing the Health Benefit Institute. We would recommend that this model at this point be sunset from our standpoint. There's nothing really substantively wrong with the model. It's just there's a lot of churn around the market. Certainly, we've got, there's been limited adoption of this model. It goes, there's not a lot of consensus around this as a model going forward. We've got an ongoing lawsuit with the existing Biden rules, which replaced the Trump rules, and the Trump administration is likely to act. So at this point, we think that there's enough turmoil in the market that even if it makes sense to have an NCOIL model, it may make more sense to relook at this down the road with a different model. Thank you. Just our thoughts.
Yes.
Thanks.
Yeah. Appreciate those comments. Anybody else? Any other interested parties? Okay. Thanks, everyone. I'll be sure to discuss these comments with staff, and then obviously Will and Ann's here on the call today. When the committee meets again in April, we'll have an opportunity to determine what the next step is with this model. And obviously your comments just now will be taken in. Anyone else have any questions or comments on this? Again, please reach out to myself or to the NCOIL staff. Is there any other business that anyone would like to raise before we adjourn here in a few? I hope everyone on the call has been registered. I hope you've got your hotel rooms booked. I'd just like to remind again, make sure that happens. If you haven't yet done so, please do it. Let's get her done so we can make sure we're prepared. And the conference has sold out, but we do have some extra rooms available at the nearby hotels. If you have any questions on that, please reach out to our fabulous NCOIL staff. Hearing no other further business, I'll entertain a motion to adjourn.
So move, Carl Anderson.
Thank you, sir. Can I get a second?
Second, Paul Etke.
All right, thank you. All of people say, have a great weekend and we'll adjourn.
Thanks, Sarge.
Thank you, Sarge.
Thanks,
Thank you,
Sarge. See you
guys.
soon.
Thank you.
Thank you, guys.
Thanks, everyone.
Good day.